thank you to everyone that's on the call today. As I'm sure you've been hearing us explain, we're very excited to see we already have this number of attendees. So again, thank you all so much for being here. I'm just going to go over a couple of quick housekeeping items, and then I'll let Beth introduce our guest for today, Jennifer. So the first housekeeping item is just typical Zoom housekeeping. Please keep your microphones muted. You don't have to have your video on. This is a recorded segment, so you might want to keep your video off. We'll have the recording posted on our website after the session is over within about a week or so. But if you do have a question, we encourage you, please type it in the chat box as the segment is going on. We love interaction with the audience, so please, we encourage you to ask your questions as the presentation or conversation is going on. And also for any of our dietitians that are on the call, you can earn 1 CPEU for attending today. We are an accredited provider. So I'm going to include in the chat box the link to complete a survey to get your CPEU after the session is over. You'll see me plop it in a couple times because any new people that join the call won't see previous things in the chat. So if you see duplicates, I'm just trying to make sure everyone gets it. But with that, I will let Beth Kitchen introduce our guest for today.
Thank you so much, Tara. We are so excited today, first of all, to see so many participants here. So thank you all for coming. I am very excited to welcome Jennifer Thompson. She did her undergrad in nutrition at Auburn, and then she did her internship and master's degree with us at UAB. And I would really like to ask Jennifer to start out with to tell us how she got here as owning her own business, because this is a topic that, and I may be speaking for some of you as well, that makes us a little nervous. This is something I kind of fear talking about, going into private practice, coding, billing, all that kind of stuff. And yet I also want to know more. So I want Jennifer to tell us a little bit about her path to owning her own very successful business.
Thanks, Beth. Thank you for the introduction. Thank you for the opportunity. I'm super excited. I have a special place in my heart for UAB because this is actually what got me started, was the programming through UAB, certainly to set me on my journey in the dietitian world. So suffice it to say, I will not tell you the autobiographical journey of me today, but just a little bit of background is right out of UAB, I was working with eating disorders, working in that outpatient realm. That's what I really like to do. I worked with a couple of startups. So just learning to launch business, the wins, the woes. But in 2014, I actually made a move. So I moved from Birmingham to Dothan and I took a clinical job. And at that clinical job, I was kind of learning the ropes of some inpatient, some outpatient services through the hospital. And that really started to kind of plant that seed way before now, way before 2021, about opportunities in outpatient, how hospitals do it, how other lab companies. I spent some time working for a diagnostic lab, consulting with them, seeing patients. So I've had kind of this wide variety of work experience, but it truly comes back to connecting to patients. What are dietitians out there to do? And I hope if anyone hears anything today, you can start just about anywhere, be it clinical, be it the ICU, be it, outpatient. If it's diabetes counseling, I've done that as well. There is a huge need for dietitians. And so there's any entry point, really. That's my opinion. But I hope you take away today that there are so many things that can create access for the public, for your patients to have a dietitian working with them. So again, I wish there was one solid path to how I got here, but I think it's wearing a lot of different hats and being open to some opportunities, maybe open to some hits and some bombs. I've been there as well.
And sometimes I think that's how we get where we are, realizing that we're not happy with what we're doing. There's got to be something else. One of the things that I think we really need to talk about throughout this whole presentation, and I always come back to this, is that we as dietitians are far too used to doing things for free. One of the things that you talked about, Jennifer, was being in a clinical situation where the hospital you were working at was not getting reimbursed for dietitian services. And so we have to change our mindset and say we're worth it and we can be reimbursed for our services. It's not just good for us as individuals, it's good for the entire profession.
Absolutely. And I think, trying to kind of construct in your mind, you have to start somewhere. Even if there is, you said fear, you said this kind of makes me afraid. And I think that's healthy because let's look at what's going on. I think it's also kind of urging us to look at how there's a change in our own profession and our healthcare system. I work directly right now with primary care. And so it's not specialty medicine. A lot of people think, oh gosh, specialized medicine or specialty little niche type setups. I'm getting more clients, more referrals, a lot of fulfillment out of the primary care world. And I'm going to talk some about how primary care is really driving this, but also it's helped me to foil like what I want to do. How can this be something that I like, that I want to do? And that's kind of that entrepreneurial sense. And I say on my slide deck here, I'm a multi-passionate entrepreneur because it's okay to have different things that you want to do. And for me, and sharing with this audience today, in May of 2020, kind of the height of COVID, the uncertainty, our department was restructured and I was actually out of a job at that point. So I was able to, speaking of fear, fearfully kind of think about, what do I need to be doing now? And how can I get back on track without total panic? And so that's where this has come from, kind of a blow to the ego, I'll be honest with you. And then saying, all right, well, here's how I could do it. And so that's what I'm sharing a little bit of today, my own flair, but just making this accessible and like imaginable to our audience here today about the realm of dietetics and what we can do. It's big.
Sometimes when you're low, that's when your most inspiring moments come, because you feel like it might be the end of the world and you're like, no, I can do something even better than this. And sometimes you look back and go, I'm glad that happened because I wouldn't be where I am right now had that not happened, even though I felt really bad about it at that time.
Absolutely.
When you graduated, this just popped into my head. When you graduated, did you ever see yourself where you are right now in private practice, owning your own business? If somebody said, this is what you're going to be doing.
Well, maybe. That's a great question, because now I don't see myself doing anything else.
Yeah.
But in the same way, it's kind of like added on, it's built on. So I think that anyone in my friend circle or family circle will be like, yeah, you being the boss of you. Yes, absolutely. So
they saw it in you.
Don't have to be that way,
right.
Of course, to be in where I am or kind of how I had it. But
so step us through this. So step us through this. Let's say, I'm sure a lot of the dietitians who are here today are thinking, this is something I might want to do. So what's the first step? Where do we start with, obviously, the mindset of I can do this, this can happen, this can work. But then what's the next pragmatic, step that we have to take?
Sure. So, and I'm just honoring here, just in headspace. I think you're right. A lot of people may be thinking like, okay, where are we? What are we even talking about? I feel overwhelmed, but I think one thing, just to hear it out, that might be something that just kind of sit with your discomfort for a little bit. I think getting started also starts thinking of like the business of healthcare. And I don't know if everyone's heard this, so I'm just saying, hear me out, to say, you're in the business world, whether you realize healthcare is a business, but putting on your business hats, thinking about, you're in sales. We're selling this. So I know that we're talking about medical nutrition therapy and how that's covered, but also we're kind of entering this business portal, and that's, transformative. This profession is transforming. Dietitians are stepping into this. I wish I was the only one doing this. I'm not a pioneer. I'll think of another word. I'm certainly not the first to do it. And there's just tons and tons of opportunity. So when we're thinking about, okay, how do we get this started? It may be the infancy of, should I talk to someone about this? Or maybe it's in your workplace, or maybe it's defining what that looks like for you in private practice. So just all of these things really to kind of start aligning with maybe business, administrative, kind of an overview, if that makes sense to.
And one of the things that when we were, talking about this segment that you said is it's important to, first of all, be recognized as a practitioner. And one of the ways that you sort of talked about getting started with this made it less scary when we were talking about it. And that is that connecting with a primary care practice.
Sure. And I think primary care is such a hallmark in an entry point. Let me tell you why. Because first of all, unless you've been living under a rock, and I mean, all jokes aside, our health system is really strange right now. It's broken. It's going broke. And so right now in our midst, there is this transition of how we're paying for that business. But what primary care really draws out, and if you hear nothing else today, maybe this is top 5 things you might hear today, is this idea of value-based care. Now, value-based care comes from this idea, and it's very, very popular in primary care. Instead of numerous procedures, numerous things, more services for pay, it's quality. It's how well you're doing it. So controlling costs by looking at how well your interventions are working out. And really what our dietitians need to hear today is these quality and value and, how good is what you're doing, how it's working is diabetes, is weight management, BMI, hypertension, A1C, other lab values. And guess who does that? We do. We're perfectly versed in that. And so dietitians really, I feel, are expertly positioned to kind of leverage their skills. And so maybe this is the first time that you're hearing anything about this, and there's a lot of literature, so that's good. There's a lot of YouTube on value-based care, but I just want everyone to understand that primary care really opened a door for me, and they care. They're your first line of every patient. And so it's something that dietitians just can hear, that you could have a sound referral source, you could be connected to your docs and help patients. I think that's another bottom line of dietitians at work.
Tell us how you connected with the primary care practice, and you do other things besides that. You have your own clients as well, but part of your business is working with doctors in a primary care practice. How did you connect with them and make that first connection?
So I actually, I speak in a lot of metaphors and I'm a little bit silly, but I just put my dog and pony show together. I reached out to friend of a friend and said they were looking for a nurse. They were looking for maybe a diabetes educator. They had this very foggy idea of what they were looking for. And I was like, no, you're looking for a dietitian. That's what you're looking for. And so I actually just cold called. Yeah, I did that thing in sales you're probably not
Love
supposed to do, but just said, hey, let's talk about it. And that one conversation led to, can you talk to our doctors about this? And I said, yes. And then I immediately was like, what have I done? I don't know if I can talk to doctors about this. But essentially just taking the opportunity to say, yes, I would love to come talk to you about this. Now, I did put together a presentation and I made it very compact. Physicians have a very short attention span and I love them. But that's really what set in stone. And I'm going to share this in later slides, but also talking about reimbursement potential, money to be made, revenue created, and their ears kind of perked up. And also knowing the system, which is why, we're talking about billing and coding and payment.
Mm-hmm.
But they were kind of like, okay, just, yeah, sounds good. Go for it.
They take care of that. In that situation, they take care of that for you. You showed them what the codes are, what they need, but they actually submit that stuff for you. So this is sort of a safe place for somebody maybe to start if doing it so completely on your own is a little scary. Hooking up with a private, with a primary care practice is sort of a kind of, I don't want to say baby step, but a little bit of a more secure way of doing this. And you have to be bold, you know, do the cold calls, make connections, talk to people. But it sounds like a sort of safer way of getting into it.
And I think what you're highlighting is just my thoughts. So I'll speak for me. I've got to go create a business. I've got to set up a business. I've got to do all these things. And yes, there are tons of people that do it. At the time, in my feeble ego state, I'm just calling it for what it is, knowing that this is just a way to partner, to say, look, everything isn't on the line, but they need me and I need them. It works out. And so, yes, I think that primary care is a huge gateway. I'll say gateway. You say baby step, I'll say kind of gateway to getting into serving this on a bigger scale and getting paid for it, certainly.
Yeah, so it's a great way to take that first bold step. And one of the things that you have talked about, Jennifer, is that the first step is really getting recognized as a practitioner and getting credentialed with insurance companies. We've got the credentials, we're registered dietitians, we got the street cred, so to speak, but now we've got to take it to the insurance companies.
Yes, and I think there are just some basics, certainly. And I'm going to go over these, but I want it to be understandable, and that whatever is the big scary monster will just kind of, the only way out is through. Is that the saying? You just plow through that.
Yep.
But here are some basics for that. We're going to talk a little bit about each of those. I first am highlighting, Beth, before right out of the gate, MNT, medical nutrition therapy, is proprietary. It is not something everyone can do. It's quite detailed. And this is the language that actually comes from the Academy. The Academy website is very busy, but has all of these things listed, but it's certainly detailed. It's not just here's your sheet. It was so nice to meet you. See you later. See you next time. It is actually relational. It's not just transactional.
And the Academy has a toolkit for this.
Right. So there is a toolkit, very lengthy, but it's some, I forwarded it's the MNT toolkit. It is on the Academy website. If we could send that out to anyone who's interested. It's big, it's free. It's something that you can download that walks you through everything. But the Academy, again, has already constructed this. Again, I'm not the pioneer. I'm just the forager out there. But thinking of medical nutrition therapy as a unique service, and that too makes a big difference when you're setting up a practice, or when you're getting started, or when you're wanting to partner, is like, hey, I do this unique thing that you can't do. And I think we have to be okay saying that too.
Mm-hmm.
Say, I know something you don't know, which might be my autobiography, is what I just decided. But the first thing is where you're going to do that and how you want to set that up. And then if you want to take insurances that are maybe federal, like Medicare, if you want to take private insurances, there are some things that you get to choose. So it's not an all or nothing.
You don't have to be all things to all people.
Right, certainly. And that may kind of allow us to breathe into, okay, I don't have to do it all the time, but you do want to think of a business. Remember when I was saying business, we've got to have a location. We've got to have some type of tax ID information. And then you also want to make sure that you have a way, and this is important for what we're talking about, that you are documenting, because there's still documentation, and that you can provide maybe client communication, patient communication, and it's usually in the form of some type of electronic medical record. So don't hear me say you got to go out and pull in something that like UAV has, or that your local doctor's office has. There are different platforms. I've listed a few here. No conflicts of interest. I'm not a salesperson or representative for these, but there are ways that you want to support your business, just like you would a scheduling, or just like you would documentation, because you've also got to get paid, remember? So they've got to take what you've done and pay you for it. So just some ideas of getting started. And when you're mentioning getting started, the biggest step, and hear me say, you're only going to do this only once, but it's called credentialing. And the credentialing process really is about the fact that you get an NPI, which is a national provider number, completely free, and that you are enrolling or setting yourself up to be connected with whomever you want to be. Okay, so maybe that's Blue Cross Blue Shield of Alabama. It's one of our biggest payers. If you want them, that's fine. You still have to credential. You still have to be in network. Now, slightly jargony, the CAQH, which isn't really an acronym for anything because I looked, the CAQH is an online tool that's developed in the recent years that basically, if you fill this documentation out once, it houses it for you right there. And anytime you want to enroll, you just go to your digital binder. I put that on the screen here. So you have these tools. Again, it's 2021, we're progressive. But you're wanting to say, I want to participate. Now, not all insurances are going to let you. Not all of them do that. And that's okay. But you want to ensure that you're in a contract, that you've negotiated about prices, that you've negotiated some type of agreement. And there's some public fee schedules. So you might be thinking, well, what would I be negotiating? There are some set fee schedules also on the Academy website. Happy to share those as well, but there's kind of a going rate. And then once you credential,
on that topic, can you tell us what that going rate generally is?
Sure. So think about it this way. If you're an independent provider, there's a rate. And if you are associated with a facility, there's a rate. But on average, let's say an hour of your time, give or take, might be reimbursed at $120, $160. And I say that because, again, remember, think of size. You're a smaller practice or you're a larger health system or a larger entity. They offer different ways to reimburse. And I also, I'm piggybacking this, that value-based care that I mentioned, when practices are doing well, they're incentivized. So imagine you're working with a practice who is recognized for their value-based care and you get double. It's a thing. And so I think that we're minding two things. One is good care and good quality, but also repayment. That's important. And so as you're doing better, as your patients are doing better, everyone wins. But for credentialing, if you want to say, I want to be in the club, you only do this one time. So this is a big part. You're kind of saying, I'm putting myself out there. But this is just heavy on the front end, and then you're done.
So you don't have to look at this constant slog through this.
Right.
Yes,
you're not
challenging at the front end, but one and done kind of thing.
Right. And this essentially is just recognizing that you speak the language of a provider. I'm a provider. This is what I do. And then that's it. So that's step one that we've kind of been honing on here.
All right. So what is step two?
I'm so glad that you asked. I want to talk, let me just kind of lay out what we're saying here. And again, in this amount of time, we'll keep it an overview, but insurance basically is Medicare sets the tone. So let me engage you on the Medicare for 1 second. Medicare Part B is based on coverage explicitly, no questions asked, all good, for diabetes and kidney disease. That also sets the tone that every time a dietitian would see them would be a referral from a doctor. Not a nurse practitioner, not a PA, but their doctor who's providing that care. So unfortunately, it's not their pain management doc looking at blood sugars. It's not their nephrologist, which sounds kind of sideways, but probably their primary care doctor. See how that always comes back to primary care? And again, the tone that's set is this benefit. The benefits are in time. So here just on the screen, and if you're able to see it, I'm just going to say that initial year, there are 3 hours of MNT, of that medical nutrition therapy. Subsequent years, 2 hours of MNT. But think of it this way, your doctor that you're working with, because you need them, can say, well, we need a little bit more time. And again, insurance is all about negotiation. This 3 hours or these 2 hours are typically based in the calendar year. So January to December. And they don't roll over year to, you want to use them. And I'm stating this because not everyone's benefit looks like this, but this is, again, Medicare sets the tone. Even our legislation.
And when you say Medicare sets the tone, what you mean is even if you are not credentialed if you're not seeing Medicare patients, they influence all the other insurance companies, kind of follow their lead.
Yes, and think about it, and you said it best. Following the lead often means, what does the research say, and how much time should we allot, and what does that cost effectiveness look like? So again, it's a federal program, so it goes back to policy. It goes back to what does that look like, and then often what private payers like your Aetna, your Blue Cross Blue Shield, your I'm thinking of like Viva or
Mhm.
other private payers, what they do. So they're the gatekeeper on this too. It's just good to know like where this comes from. And as
Right,
policies change and open up, um,
right. So even if you're not a Medicare provider, pay attention to Medicare, the
certainly,
policies.
certainly.
Coming down.
Just a tidbit here is the legislation last year that involved the Malnutrition Act of 2020 really was headed up by Medicare. We really wanted to have their ear. Again, as we influence or as dietitians are moving towards things, Medicare, big piece.
Mhm.
Um, Important to point out, Blue Cross and Blue Shield of Alabama only recently, thankfully, but only recently in 2020 opened their network to dietitians. So we are able to provide services in their network. They use M&T through their preventative benefits, and they've even had some expansions the beginning of this year. So you can see this ebb and flow. 2019, nothing from Blue Cross Blue Shield of Alabama. 2020, welcome. 2021, here's more. So I think
Yeah.
I'm saying I think that we have to see this trend. It's not going away. I think that we're going to be in the conversation, and we're going to be able to do more things if we participate. So we have
And
to.
I feel like I got a letter from them saying we're now doing this, and if you want to be a provider, and of course, being the scared person that I am, I went, and filed it in the trash because I was like, that's not me,
But you were like, this
So,
is so thoughtful that you thought
yeah,
of me.
it's so
But
nice of you. Thank you. Yeah.
yeah. So
Maybe
and
later.
again,
Maybe
hey
later.
Beth, you're speaking it. You get this packet that's got 17 stamps, and you're like, I gotta fill out, 45 pounds of paperwork. And it goes back to that credentialing. If you want to be in, you
You
fill the
slog through
forms
it.
out. The only way out is through.
Right. And it's
Two
one
things,
time, just one time. Yeah.
two things for like Blue Cross Blue Shield of Alabama is that it's a continual conversation that dietitians have impact over, but it's a conversation for doctors, for medical providers, for healthcare administrators, to say we need this. We need them to say it too. We need everyone to be saying this is important, and not just saying that it's important, but even showing their outcomes, showing their data. And
Mhm.
back to value-based care, which I'm going to do this whole time, is based on outcomes. You'll hear it here a million times. Medical nutrition therapy and insurance, it already exists. So under most plans, you're in there somewhere. And I'm saying you, even as a listener, like your coverage is in there somewhere.
Mhm.
It's continuing to expand, but it is based on diagnoses or some type of preventative care, and it is in the medical realm for sure.
Let's talk about the ICD-10 codes that we might need to be familiar with. Are you ready to talk about that, or do you want to talk
Yeah,
about?
no, you're
Yeah.
spot on. You're spot on. I want to mention that when we're talking about diagnoses, really that's because it's coming from a doctor. So just the bottom line is we need our doctors to
Mhm.
pipeline us these patients. And when you get a doctor's referral, you usually get an office note. You get some type of diagnoses. You get the insurance information. So it benefits everyone to stay in the loop with your doctor versus, oh, I don't know what's going on with this patient. But when we're providing that MNT, we need that data from the doctors. We need this information from the doctors, like why are we seeing them? And have the patients been seen before by a dietitian? And let me show you just a little bit when we're talking about ICD-10 codes. Some people's eyes may be glazing over like, what? Look, even Google houses a free way to look at this. You can look up any diagnosis, but the language of coding. Some people probably can code. I can't code computers on here, can code visits. But these, if you'll see, I've underlined type 2 diabetes without complication is listed as E 11.9. Well, that's all they want. They just want this is this. Juxtapose that with this Z code, and you can see that diabetes is all the E's. It's the whole alphabet. All the Z's are counseling, preventative, surveillance. And so we have one that's Z71.3 that's pretty ubiquitous. And I'm showing this because, let's say, you're like, is this covered? A lot of times there's coverage to be found kind of all over. And this Z code, now some physicians can use it, talk for a different day, but it is one that's found in most preventative benefits. So even if you're like, ooh, I'm not sure if this is covered, which we're really not talking about those specifics, you're just using their numbers to communicate what you did. That's all this is. And when we're talking about, well, what do I do with all this information? Where should it be? I just want everyone to hear that you do need to be pretty attentive to what you're documenting. And that's so 2000, whatever, whenever I was in my internship, document. And it's still here, still exists, but you just need all of that data. You need the patient's name, the date of birth, the medical diagnosis, you need the physician's signature. So you need all those things. You need the date of service. Another thing that's really important for everyone to hear is you need times. Time in, time out, time spent. And I'm going to talk a little bit about why that's important.
I was going to ask you, talk about how we divide up the time, because that's a very practical thing that I think people need to sort of know, that there is a guide for that.
Right. So I said, coding is a language of payment, but it's also like how long you did that. And, when did they come in? When have you, cumulatively, how much time have you been spending with this? Because they're going to process that. And again, if folks, let's say your patient has a certain amount of hours, it's time-based. So time is important. Ultimately, time is important. And before you read this and say, oh my goodness, she's gone Matrix, she's gone on us, is that our codes are time-based. Our common procedural codes, our CPT codes. And when I'm saying our, I want you to take a look at my matrix level of coding here, that it's MNT. We have them.
So we've got the diagnostic codes, and now we have the actual billing codes. So yes, we got to keep those two things.
You're right. Great point. So those ICD-10 codes are
your diagnosis.
What's wrong with you? And the billing codes are here's what I did, and this is what I like to be paid for. So after you've seen the patient, you're going to code for the visit using these. And guess what? This is just about it.
Wow.
There are the exception of potentially some telehealth codes that have emerged, some change in diagnoses codes, but for our practical purposes here, reducing fear and increasing awareness, there are really three. You've got an initial, you've got a follow-up, you've got a group. But the reason I keep hinting at time and talking about time is they're measured in 15-minute increments. So go back to your carb counting. We're going to be counting time in 15-minute increments as well. And I
think we have a question here, Tara. Sure. Do we have a question?
Yes, we actually have two questions that relate to what you're talking about, Jennifer. The first is, are there standardized record keeping forms available, or do you keep records using your own forms? So I think this is referring to all the patient information that you need. And then the other question is, do you offer telehealth options?
Okay, both great questions. The first question is keeping data. Now we want to remember patient privacy is really important. So you can't have everything on a Post-it note in a file somewhere in your car. So when I mentioned at the beginning about either electronic health records or web-based platforms that help support your practice, they can keep all that data for you. So that's a very high level. There are ways to do this on paper. There are certain forms that you would fill out, that you could handwrite, that you could complete, and you could submit. But I will tell you, in 2021, almost everything is transactional. So that kind of answers the question about patient information or patient data, or when you saw them or what you treated them as. I use an electronic medical record that will keep up with that, so I could always pull it. Some that are very sophisticated, you could run a report. The second part to that is I actually have an Excel spreadsheet where I can de-identify patients. So maybe they just have a number or a clinic number. And I try to make sure with visit 1, visit 2, visit 3, visit 5, 10, that we're in that window, the window of time. I also, and Tara, this is actually a great question. is I just speak to what their insurance says. If they say they have 3 hours, I tell the patient, your benefit says you have 3 hours. And usually that level of transparency, folks will say, okay, so I've got this much time. I hope that kind of explains the question. And then telehealth, let me be clear that, 2020 was a rough year. As far as opportunity to provide telehealth services, it really unlocked the box. So prior to 2020, there was no telehealth rendering of services. Now there is. And to keep it simple, I'll say that with these codes I've listed on the screen, just indicating telehealth. I'm simplifying that, but just my place of service, telehealth. Now, telehealth, and I don't think I included that, is not a public facing, not a Zoom call. Okay. It's not like an Instagram live where Beth, you join me and I say, hey, how is it going? But it has to be either audio visual that's HIPAA approved. Again, most electronic health records do that, or it can be audio. And again, time just necessitated that. So there are ways to do telehealth. I'm just saying this for
And
a caveat.
I think the pandemic was a real game changer for opening it up. I mean, we had messages saying, we're kind of lightening up our HIPAA regulations during this. We're going to not be as tough on you guys with privacy and all that kind of stuff. And then they'll probably pull that back a little bit. But I think it really opened this up. It's a conversation that a lot of doctors groups are having about telehealth, and they were doing drive-through medications and all kinds of things at the beginning. So
so we're innovating. We're innovating in that way. So there are opportunities to do telehealth. I always feel like I'm living a footnote at this point, but within reason, within whatever you're credentialed to provide. If you can't do X, Y, and Z for telehealth, your agreements will say that. But what I'm saying is, for, let's say, example 97802, if you're going to do a telehealth, you can simply put that in your documentation.
Great.
I'm hoping that it will stay, though, Beth. You made a great point.
I think there's talk that it's going to have changed medicine, that this is going to be an ongoing topic.
Sure.
We have so many people in rural areas that are not getting the care that they need because of traveling. And so I think it is going to be something that's here to stay. What it's going to look like, I don't think we know, but it's good. You're on the forefront of it. And I think that's exciting. Now, we do have some case studies that I really want to get to, but I do want you to touch on, some of these topics that you want to make sure people know where at least to find the answers to before we get to them.
And I'll highlight here, because we do have those. We have some case studies where you get to be the dietitian in this case. That Academy Toolkit, all of those things are listed. They actually updated for 2021. But just to highlight, billing. If you're saying, okay, 15 minutes, what does that look like? This actually breaks down the 8-minute rule. So for however long you're spending with the patient, you're just accurately and appropriately coding for that amount of time. So just put that up here. And I want to say this too, just for tips for accurate coding. When you're using your time appropriately, it really reduces the amount of denials. So that's a plus. People aren't going to come back and be like, oh, actually, you can't meet with this person for 4 hours. It also, you can be dinged for not documenting the amount of time. So time is important. And when I said I have an Excel spreadsheet, I like to keep track of the patient time. Because in a loving way, that first session, people just want to tell you everything. And I want to hear it. I want to listen. And I'm working very mindfully to listen better, but you also have to.
Time is money, right?
All right. Something to think about for usual and customary practices. You can divide up this 3 hours, which, for most people are like 3 hours. That's a pittance. You can't do anything for 3 hours. Okay. The cards were dealt are 3 hours. Ish, unless you want to beg, borrow, and steal, which, it's always a negotiation. You could divide those up, like an initial and then 4 follow-ups, averaging 30 minutes. I do want to be very cognizant that just because codes exist doesn't mean you can use them. Even if you go in and say, well, there's one for this, and I'll just use it. If it's not stipulated in your contract or really not an MNT code, we have to be very, very. If you're wanting to be paid, All of this is going to create a claim. Maybe that goes through billing that you use, maybe your electronic health record, but that's tied to payment. So the reason that we're doing this system, and you might be saying, whew, why am I credentialed? Why am I documenting to this link? Is because it's so you're paid. So you can process those benefits. You can look at what's happened. And
quick question here. How long does it take you? Let's say you've done everything well and they're not denying the coverage. How long does it take you to get paid from the time you have submitted the bill?
Right. I'm going to point out that there's something here with a correct non-issue bill. 2 weeks, 4 weeks. 4 weeks would be a very long time, but I will say that I've seen something kind of linger and I'm like, where is this? I do have folks that have maybe an out-of-state claim that aren't in a hurry, that have lasted. But I think that in timely billing, like you see them and you get it in under 4 weeks,
That's
potentially
good.
average 3 weeks. But that's a great question. It also depends on submitting paper claims, or if you're with a large practice. And here's something I'll attest to is that, so I'm with Fairview Clinic is my clinic. And, they've got them cranking, they've got them coming. And so if there's ever an issue, it's just a little speedier because someone has their eyes on it. I put up this graphic and only to say, if you credential, you're a medical nutrition therapy provider, and then everything else flows around there. The screening, maybe you're screening your patients. Is this who I want to see? Is this who I can take? You're rendering your service, you're coding those visits, you're billing for them, you're providing a claim, which is a paper trail so you can be paid, and round it goes. I made that's the most simplistic graphic that exists.
Yeah, but it makes a lot of sense. It makes a lot of sense. When we're looking at this, a couple more questions before I really do want to get to the case studies, but how much time do you spend with your patient versus time doing sort of administrative paperwork, that kind of stuff?
Right. So splitting up time is something I'm getting better at. I would divide it up. I spend about 60% of my time with patients, so like in the office, seeing them, like a busy day. I mean, back to back. And I feel encouraged that I'm spending most of my time with my people. I mean, that's I would say
that's what you're there for. You want to
right. And I would say 20% is, and I alluded to this a little bit, like scheduling. If you have an MRI, you know what to do, right? You're like, okay, I have an MRI on my knee. For folks who, this happens all the time, who are receiving a dietitian consult, ooh, they got lots of questions. Who are you? Are you mean? Are you the can I afford it? I get that sometimes, but they just want to talk. So 60% actual stuff. I would say 20% scheduling, setting up, squaring away everything on the front end, which actually is diminishing as I get better at this. And then I would say 20% of the time administrative. So if there are denied claims, my office is like, what's going on? And that just allows for that time. And it's built in. I try to understand that. I'm not
it does seem that the more you do this, the better you get at it. And you get to spend more time with patients, less time doing that. Quick question before we get to case studies, very quickly. Now I forgot what I was going to say. This is going to be case study. No, it popped back into my head. Do you sometimes have to call insurance? Like, do you have to actually, you have this patient and they don't know how much is going to be covered? Do you have to square that away with the insurance company to see?
I do. Now, again, remember when I said I'm not the only person doing this? Other dietitians may have different systems, but here's what I've seen maybe since November. I started in November filing claims with my primary care office. I've probably seen 5 denials in November to currently that we just had to refile. We just refile them pretty timely. I'm off track in saying that, but remind me your question, Beth, because
it was do you have to call the insurance company yourself?
I got caught. I lost track on.
I lost track on the
why
question.
were they denied? So I call mostly because it prevents a second call to the patient. If I get a referral and I call United, I say, this is my wait for it, watch this. This is my ICD-10 code. I'm providing 97802. Are there restrictions? Is it covered? Are there any reasons that I would not see this? Is there a benefit? And they're like, no. So then when I call the patient, you have a $30 copay. We can see this. You have 3 hours of time. I would love to get you scheduled. So it prevents the calling and recalling. I do this each time.
It saves you time down the road.
I do this each time, so no one's confused.
Right.
With insurances having online portals, I can tell you that sometimes it's a login instead of a call, which calls tend to be a phone tree. So that's a plus too. Yeah. My system is that I call first, so I know what to anticipate before I see them bill it out, and
right.
We can't do
so
it.
Let's get to the case studies, because I think this is one of the most useful things we can do. And Tara's going to be helping us out with some poll questions. So everybody get ready to answer some poll questions and see how you do.
Yes, great. So here's the good news. You cannot fail. This is a pass only class for our questions, but I want you to, maybe everyone's shrugging upward now, and just let those shoulders sink down, take a deep breath, and think about this. The dietitian will see you now. So you're a provider. Pretend that you are. Imagine that you are. You see Blue Cross Blue Shield. You have Medicare. You can take TRICARE, Humana, Aetna. These are your people. And your office is in a primary care clinic. So you're kind of like me, but better. And you have some patients. So let's get down to business. Speaking of business. So if you're able to follow along, I'll glaze over this, but we have a patient, LB, referred by primary care. You have the ICD-10 codes. Here's some demographics. He was educated in the past by a CDE with no MNT, nothing on record. He's got blood glucose that's up, and that's for a variety of reasons, but his doctor's added a medication, but he's not going to fill it. He doesn't want to do that. He wants to be on fewer meds. He's active with Medicare, so you know that. You've reviewed those meds. You've reviewed his labs. Those are listed here, and his trend is up. You have his biometrics. You've got his BMI, your height, your weight. And so I just want you to kind of conceptualize this patient. Mm-hmm. And think about what affects whether you can see him. So right now you're going to see a question come to you just magically. So what factors affect whether this visit is covered? And again, there's no right or wrong. But just thinking about that, and if you'll contribute your answer, I do not have a playlist that we can play. There is no Jeopardy music, and I will not sing. So
I have a question for you while you're waiting for responses.
Yeah, absolutely.
So someone had asked, since nurse practitioner referrals aren't covered with Medicare, is it the same for Blue Cross Blue Shield?
So here's my short answer to that. It's just minding who is in charge. So most nurse practitioners bill under a physician. So it might be that your claim is denied because you entered, this is the provider, when really it's just it's the, try not to say superior, but it's the supervising provider. Blue Cross Blue Shield tends to be less of a stickler about that, just anecdotally. But I think it's good, it's good practice to know, because a lot of people have a nurse practitioner as their primary care provider. So it's a great question. It's a quick fix if there's an issue. That it could be the difference in them saying, oh, this provider is not qualified, and you're like, whoops, I actually meant this doctor. You resubmit that claim. And that's a question to ask. I mean, I think it's insightful for whoever asked, is you could ask that to Blue Cross Blue Shield. If you get this patient, you could certainly ask that.
So what's the answer? Are we ready to look at the poll?
We have 61 people voting in.
61%, yeah.
61%, yeah. But we can.
Are people still working on it? Are they still working?
I'm wondering if anyone's on audio only or phone. I'm not sure if they can see.
Yeah, they may not.
But we've been rolling for 2 minutes. Let's end this poll so we can check this out. So anything that will affect this diagnosis is just that it's diabetes. Remember Medicare and diabetes.
Mhm.
Okay. If he previously worked with a CDE, it's not MNT. It's okay. If let's say he lives 40 miles from this site, you know, is that an issue? Not necessarily. If he's self-reporting non-compliance with medicine, well, it's really not, it's actually not an issue. So again, the coverage really is dictated by this diagnosis, and it's diabetes. It's Medicare, diabetes, Medicare. Perfectly married. I'm gonna take those off. Let's launch one more about this, because thinking about the same patient, if 40 miles away, they can't travel, or maybe they're not willing to, what can you do? Like, you could explain that you can't see them, you might want to refer them, you could make a home visit, telemedicine visit, audio, video, both HIPAA compliant settings, or you could set him up. Let's say you're a perfectly private practice and you could do an MNT on a Facebook group. So these are the options. So think about that. We'll let that roll through, and I'll kind of mind how many folks we have. So Jeopardy music.
We should have queued that up, had it ready to go.
Next time we'll do that.
While people are voting, I'm going to ask you the big, I think this is okay to ask this now. This is the big question that probably everyone is thinking. Can you make a living?
My
off
answer is yes.
Yes.
And my answer is yes for a variety of reasons. One is that this is just for the taking, and you can titrate it how you want to.
Yeah.
If you have a private practice, if you want to be exclusively seeing patients, people are doing it all the time, and across the US. On my title slide, my academy group is the nutrition services payment specialist. So I'm in connection with all dietitians across the US about coverage, and people are already doing this. Now,
so you have a lot of resources there, a lot of support.
Well, and it's available to you here in Alabama. If you're from elsewhere in the state, certainly, but people are doing it, and I think it's very viable because it's only going to grow.
Yeah.
That's my opinion. Is we're only going to see the advent of dietitians becoming more like providers, because you're going to max out on meds. You're going to there's only so much time. And my other thing before I answered is that to combine this idea of our time-based codes. Time is money. You know who doesn't have time? Doctors. They're in, they're scheduled, they're double booked. And do you know who has time? We do.
Yeah.
We bill for that time. So I think it's viable in that way.
Yeah. It's very encouraging to hear that you can make a living off of doing this. And so it's very exciting. It's very exciting. Are we ready to talk about this poll?
Yeah, let's end polling. I'm going to try to, I've got one more comment for you there, Beth. All right. So most people said, I'm seeing like 100% utilize a telemedicine, video, audio, or both with HIPAA compliance settings. Absolutely. Now, I will say that there is some language with like Medicare about making home visits, or there are some home visits that in the time of this pandemic have, and I hope that y'all are kind of flexible with me about this, that you could. The first option is that if you can't see the patient, or maybe you don't offer telemedicine, or you would prefer for whatever reason to defer, that's fine. So there's not really a right and wrong, but please also know that you cannot provide medical information with privacy data over some type of live platform or screening. But this is a telemedicine question, because you could certainly do that.
So as you're moving on to the next case study, a couple of questions that I'm seeing popping up here. Liability insurance is that you can get that through the academy.
Absolutely. That's a great question. That's going to be in the credentialing section. So any person wanting to get on board and in-network can have a professional liability insurance.
So that's taken care of there.
They have through the academy, has one that is very reasonable. Now, I will tell you, in certain health systems, in certain larger systemic groups, there are some issues about who covers that. And does everyone need to be individually covered? Is every specific dietitian? Is it overall? I don't have the answer to that, but there is a mechanism that's going to ask you for your professional liability
So
insurance.
that's out there. And then there was a question that I saw that was it's a great question. I'm laughing because I think it's like probably what everybody's thinking about but doesn't want to ask. How hard is it to do your taxes? This might be the time to have an accountant that actually does that for you.
Full disclosure, that was the first person I called, only to say that yes, I have a very loving accountant that I don't do accounting and he doesn't do dietetics, so we're good. I would say this, that I think it's great. It does make it complicated in some ways. Now, I've established an LLC, and I did not present the finer details at the beginning, but I set up a contract. So I'm a contract employee, really, with my primary care clinic. So that's another option. That's just something else that maybe if you're not wanting to take on all the risk or all the tax liability, or like, whoa, this is overwhelming. That was something that came into play for me. So I'm not saying that's the best thing for everyone, but it's just something to consider. I would also, I'm going to zoom out just for a second to say any business, if you wanted to have an online boutique, if you wanted to have a multimedia marketing firm, if you wanted to start it would still be all of these things. And so it is, for me, a constant reminder to say, well, everybody's doing this. I mean, the credentialing packet for us, for Blue Cross Blue Shield, looks just like a hospice company. I mean, it's still that same grind that makes you just need cookie dough or something. I get that. But it is kind of like that business model where we're just like, okay, this is what we do. I want to set up an LLC. You can do it online. You can go to your local attorney. Yeah. It's as straightforward as you want to make it. And I'm happy. I've got my contact information. I can talk more about it.
I think you're going to get a lot of questions. Mary, do we have time to do the next thing? It's noon. Should we do the next case study if people want to stick around? What do you think?
I think so. I did just want to draw everyone's attention to the chat. I put the survey to get your CPEU for attending today. So if you do have another meeting or obligation, you have to hop off. We understand and we thank you for coming. But let's go through the other case study for people
who go ahead and do it for people who stay with us. And everybody, just remember, this is recorded. We post this, so if you miss sections, want to go back, and Jennifer will be posting her contact information. So I think you're going to get a lot of questions, Jennifer. I think people are really excited about this. It's neat. So let's go to that next poll question, or that next case study.
We've got this case study, and we'll go through these. So here's AZ. She's a 36-year-old Caucasian female, referred to you by her cardiologist. She's been experiencing some systemic things, some exercise restrictions, and she wants to see a dietitian. Her cardiologist gives you an ICD-10 code, a couple, one for her heart disease, one for her BMI that you have. You review her medical history, and she's just in significant cardiac stress since she gave birth. So she has TRICARE. She's active with TRICARE. You've reviewed labs, you've reviewed biometrics. That's here on your screen. So how might you field this question about AZ, and see what you think? So how can you field this? Lots of data, but a couple of options here. So either you can't see her, she's got this Q ICD-10 code, she's not referred by her BCP, contact her insurer, which is TRICARE from the case study, or talk to her on the phone. Just send her some email handouts. See what you think. We'll be mindful of time. People are rocking and rolling here.
We've still got over 40 people hanging out with us, so I
love that. Time is money, right? Did we say that? While this is ticking on, Beth, your question about when we were talking about, can you make a living? I think it's also important to think about, what it is that you want to do. I'm hoping people hear this and say, aren't we billing for this at our clinic? Like, oh gosh, I know these people. I think that there is a great opportunity to just sing your own praises. But we did a pre-meeting, Tara, Beth, and I, and just talking about, if you're uncomfortable, self-promoting, it's really not self-promotion. But I'll give you an example of one of my docs that loves to have a lunchtime conversation with me. He's like, okay, Tell me about this. And it's really engaging because what it does is creates conversations to be like, oh, they know their stuff and we do. You're thinking that you don't, you do. So hear it here.
Right. And that's why, this is so good for our profession, because I'm much older than most people here. We didn't used to get paid for anything. And it lowers the profession. And so going out there and saying, I am a professional, as you use the word proprietary, we know what we're doing, we get results, and we deserve to get paid for that. And we have to adopt that attitude. And in my day, there was almost this collective attitude of, we don't get paid, we're just here to help you. And that's bad for the profession. A lot of times we feel like, but we're doing it for the good of the patients. Yes, but if the profession doesn't survive, then we can't help anybody. So I think that's really important.
Yeah, I think we have to talk about ourselves.
Yeah, we do.
Let's look at this. I went ahead and shared the polling here. So what did you all kind of group consensus is contact the insurance, ask for authorization. Beautiful, beautiful. When in doubt, you call them up and you say, it's me. Give them the info and ask specifically. I think another thing is that she hasn't been referred by her PCP because this was real life. This was a person, and based on TRICARE, well, tricky here, they were like, it doesn't matter. See how that happened? They were like, oh, you have a doctor's referral. They weren't going to split hairs about a PCP. I do want to say lastly, on talking to someone over the phone or giving them handouts, just to be very aware that if you're not seeing them in person, you absolutely can in the spirit of help, but just be mindful that if you haven't.
I think many of us I know people have asked me, hey, can you just give me a diet? And I say, no, I can't just give you a diet. I don't do that. For one thing, most likely you're not going to stick to it most of the time. And secondly, that's not professional, just to hand out diets on the street to people on flyers or whatever. So
Beth, I think what you point out too before I launch, this is our last question with AZ, is that you create desire when you say, I want to give this to you, or this is my marketing plug, is that it sounds like you're wanting this information about a diet. I'd really like for you to come in and talk to me about it. I'd be happy to give that to you. Or increasing your legitimacy to say, we don't just give it away. Like that's not something that I can do. Because you wouldn't do that to your doctor.
Right.
I know,
would your doctor just hand you a prescription for something without knowing? And I don't know anything about you. I can't really help you unless I, really sit down with you.
Exactly. You're tracking. So let's wrap up our case studies here with, let's say you get a denied claim. Dun, dun, dun. What do you do? Cry in the corner is not an option. So there's that, but there's really not, let's say there are 4 options here. There's nothing you can do. Okay. Or correct the error, refile the claim as quickly as possible. Or you could bill the patient, contact them, and then they would call their insurance for the claim issue. Or post a claim issue to your private RD coaching group, and maybe it's that Facebook group that you're a part of, and then you ask for support. So think about that. Just in denial, and denials happen. So I also want to create space to say, denial isn't you're a horrible person and you didn't do it right. I take them personally sometimes, but it's that something went wrong in that coding. So just think of it that way. It's not a personal affront to you.
And one thing that I think some people might be thinking is that when somebody becomes your patient, is there an understanding that if insurance does not cover it for some reason, even though we've done everything we're supposed to do, are they responsible for that? Because that's a really touchy situation, especially if you have patients that, are not able to pay, and that's a bad situation.
Right. I have two thoughts. One is that if you're a private, let's say you're just a private practice, you're freestanding, you do your own thing, you need to have either information in that about what you're stipulating that they pay, missed appointments, non-coverage, all that just needs to be stated. That's just a business transaction. Just tell them. Medicare specifically requires an advanced beneficiary notice. It's an ABN that says, well, we don't cover, you got to pay for. So again, you remember how Medicare sets the tone?
Right. There you go.
Again, you're wanting to say anything that's not covered, you're obligated to pay for that.
Got it.
The piece that comes to mind before I end our poll here is that one huge positive is that doctors' referrals, doctor partnerships, even if it's in private practice, if you want to put out your own shingle, there is room. There is an abundance of opportunity, and there's also, and this like can't be understated, is that it creates so much access for patients. Otherwise, that would just have to self-pay.
Mhm.
Otherwise, that you would set your rate, and if they can pay it, they can pay it. If they can't, they can't. That is a huge piece of some of just the climate of healthcare right now, of who gets it. And so this creates a better playing field, unfortunately not for people who are uninsured, but with insurance.
Right, right. So let's finish out this case study poll question, and then we will ask for any last questions for Jennifer. And
so everybody pass this one. Always refile,
Mhm.
especially in the cases of insurances. You know, you're not going to get it right all the time, but it is doing things out of our imperfection, but just doing them. Barbara Corcoran has a podcast. It's very, very short, but she said, you don't have to get it right. You just have to get it going. So that's something that I impart, that it's not going to be flawless, but it is going to be better. It's better than what we have.
just to let you know, and I think he's left, but one of our students said, if you need a long distance intern, let him know. So he's one of our students that I know is very interested in going into private practice. That's what he wants to start out doing. So I knew he would be here, and I think he's going to be very excited.
Well, you're more than welcome. It is a comedy of errors with me, where I'm just kind of like doing the conga line some days, and other days, but yes, absolutely. And I would love to get, I mean, that's a big part of this isn't a secret. These things aren't secretive. I feel that there is more value in sharing and knowing and navigating those landmines than saying, I really couldn't speak.
There's so much work out there for all of us that, and everybody ends up specializing. So you're going to start to read, if somebody says, I saw Amy Geis is on here. She's one of our eating disorder specialists who was on the show. We love her. There are going to be patients that are not your area that you might even refer to people. And we get this huge, great referral network because somebody specializes in maybe gut health. Right. Somebody else specializes in eating disorders. So
we need it.
This is Alabama. There are plenty of people to see, right?
Well, in the long range of that is working there. There's nothing we can't do when we're working collaboratively. I feel like there's a lot of power in collaboration, but also, wouldn't it be great if Alabama was a picture of collaboration, coordination?
Mm-hmm.
We've brought MNT, we've brought our MNT providers in. We're seeing this move the needle. Those are the things I think about versus every map that's watercolored, and somehow the southeastern states look
right
obliterated in some kind of dark color. I think that there's a huge opportunity.
And the last thing that I think I want to end on that you told us over and over is data. Provide people with data that you are effective in what you do.
Right. Three things, and I'm so thankful that everyone is here in a captive audience. The three things are tracking your impact. What are you seeing? What are you gathering? How many patients? How many referrals? How many denials? And I'm rattling this off as an auctioneer because all data is good data. I mean, it's all good data. I'm not even a researcher. And 10 years ago, I would have rather vomited than done any type of research. But then when you have data, you know your numbers, and you can have those conversations with insurance companies, which is happening now. They're like, how do you know? How do you know you need more time? You can compute it, interpret it, and you can share it. And when you're sharing your stories, you're sharing, and Beth, I'm calling you out because you're like, we have to share positive and negative. We have to share the wins and the woes. We have to say, this is at a deficit. This is going really well, to speak up. And I'm saying that mostly because there's an impact as far as the money to be made, the impact that we have, the influence when we're talking about writing policy. We're talking about the money that dietitians make, the
Mhm.
reimbursement, the access, cost cutting, and that creates an RD presence and an RD legitimacy, which ultimately, I've never really yearned to be an influencer, but in this case, the term influence is how we're writing policy, who gets seen, what diagnoses are covered, and that can be influence even in your workplace. Advocacy is not just to call your legislator or your representatives. That's
Right.
part of it.
Right.
You can do that throughout any system that you find yourself. So
Well, thank you. I'm sorry we went so far over. I knew we would.
no, I'm
Always,
glad.
but this is great. This is just so useful. And I think this is just phenomenal. And I just thank you so much. This has been so enlightening. And folks, you can see Jennifer's information there. I have a feeling you're going to get a lot of emails, Jennifer. So that's exciting.
Okay. Well, I put everything here. Pending your time and our kind of production time, I can answer if people are here and need something answered in real time, or if people want to email. This is actually a work cell, so I mean, you can't invite me to dinner on this. You could be the most interesting person at anywhere now at any dinner party, but so I'm all ears. Absolutely. Thank you so much.
Thank you. This is exciting. This has been exciting. So thank you all who attended and stayed with us. This is just really wonderful to see everybody here. RD updates, we're just growing all the time, and if anybody can join us, so please invite people. We'd love to have you.